son wanted to be the security guy. He claimed he was a security guy.
Welcome to an ambulatory version of Security Guy Radio. I'm Chuck, Hospital Harold, and Paul.
Tally-ho, Bristow.
Still sticking with Tally-ho. You couldn't come up with one. You couldn't come up with one for our.
No, I like Tally-ho. I've got the handle of
right.
Tally-ho. I was thinking about Secret Squirrel, but
I happen to go with Chuck Hospital Harold because we'll be talking about
hospitals,
security in the healthcare industry, right? Hospitals and things like that, which you and I have been talking about for I don't know about a year or two since Obamacare came in. Because you and I both think
the Affordable Healthcare Act. You mean?
I beg your pardon. The Affordable,
Give it a right
the
name.
Unaffordable Healthcare Act. You and I both believe that will be the next active shooter location.
I think so. Yeah, I'm surprised we haven't. Well,
we've had a couple.
Really kicked in yet.
There's been a few incidents, but we can't really tie it to it. But here's my idea. I'm a guy. Well, my insurance was canceled. Oh, I didn't tell you.
Well,
the
you're
story.
a health risk. That's why.
Well, that's true.
I'm surprised.
So my insurance gets canceled. They take me from Blue Cross when they had the golden handshake plan with the police department, right? They cancel it. I call up and say, wait a minute, I'm supposed to be able to keep my own insurance. Sorry, we don't have that anymore. Just last week in the mail, guess what I got? I got an invitation from Blue Cross to join Blue Cross after they cancel me.
Well, that's the Affordable Healthcare Act.
It's wacky. So here's the scenario. Somebody like, I don't know, a guy like me, he has insurance. He gets canceled. He picks up the public health care, and it doesn't cover his terminal illness. And he says, you know what? Screw you guys. I'm taking out the doctors in the hospital.
Who's he going to blame, right?
I think it's
hospital.
I think it's a plausible scenario.
It's not just plausible. I think it's going to happen.
I think it's going to happen.
Yeah.
And so we're not trying to, make people scared, but I think that's something we should look at in the healthcare industry. We're going to talk about that today. So it just so happens that when I worked at UCLA as a police officer, my third police department, I was assigned to the Center for Health Sciences, as they call it, UCLA Medical Center. Did you know we had 35 miles of hallways?
That's a lot.
I think it was technically the largest building west of the Mississippi next to the Pentagon. And I did a footbeat in there, right? So what I learned was that they're cities unto themselves. They have their own rules. They have their own way of doing things. And we just had crazy stories. You had a funny story you were telling me before the show about
my wife's uncle.
Yeah, he's on the public health care system in England, right?
Yeah. In actual fact, I mean, it does show that the National Health Service does actually work.
In this case, it does.
It does.
You got to hear this story.
I mean, Pat, God rest his soul, he was the youngest person to have a heart attack up to that time in the UK. And he was actually hit the Guinness Book of Records for the number of heart attacks, which was, I believe, 21 by the time he was like 25. And then eventually he had a new heart put in, right? Had a couple of heart attacks with that, but lived through he died like last year at 75, but of some sort of liver disease. So
does his record still stand?
I believe his record might still stand. I'll have to have a look at the Guinness Book of Records. Yeah. Pat Collins was his name.
And the good old now, how did the public health care system save him?
You know what? They really did. They really did do a good job, and
they just wanted to be
him. And
they wanted to be in the book of records.
Yeah, I'm assuming so. So it does work. I mean, it's it is a good system, but I'm not going to say anything about it.
Well, here's some of the stuff
Affordable Healthcare Act.
Here's some of the stuff I had. If you're what they call a footbeat officer in the Center for Health Sciences, right? So emergency rooms, big place for hostility. We have people in there that are gunshot victims, and gangs would come in to finish the guy they didn't kill. So that was a big problem, right? We had suicides. People would come to this emergency room, go outside the emergency room and commit suicide, because if they missed, at least they're going to get scooped up and taken inside, and everything was good, right? So I shouldn't be laughing, but this just shows you how bureaucracies work. I get a call one day, suicide. I get there. There's a guy on the lawn. He had put the shotgun under his chin and pulled the trigger, and he literally was
Did he
missing,
live?
Well, according to some people, all right, he was missing the top of his head, and his brain was 10 yards over there the other way. And I came up and I said, well, I'm not calling an ambulance. It's kind of a done deal. The chief calls me in. I read your report, Harold, and we have some problems here, discrepancies. Okay, what's the matter, Chief? Well, you say here that you didn't call an ambulance, and people have been known to live without brain waves. And I said, well, but his brain wasn't in his head. It was over there on the side of the grass. Well, it is a known fact that if you don't have a brain wave, you still cannot pronounce people dead. I said, you know what, Chief? That makes a lot of sense now that you said hackers. There's a lot of people running this police department that apparently don't have brain waves, but they're still functioning. That guy was, don't get me started.
You
Anyway,
could have given mouth to brain.
it was very strange. But that's technically true. You legally can't pronounce somebody dead, only a medical doctor,
Yeah.
right? So we had that kind of thing. And then the other thing a medical doctor cannot do, people don't know this, but they cannot pronounce people 5150, which is health and safety code for, being mentally ill. Only a police officer or a psychiatrist can place people on a 72-hour hold. And we'd have to come to the hospital, and the doctor would say, I want you to put this man on a 72-hour hold. And we said, no. What year is it? It's 1989. Who's the president? And what did you have for breakfast? And if they can answer basic questions just because they're living on the street, doesn't make them crazy. But the hospitals want to get them inside the system to make money, that kind of stuff. Then we had vapor employees. We had a guy that ran facilities that made up fake names and hired people that didn't exist to pay himself. Just all kinds of investigations. I mean, it's really...
it's a city, isn't it?
It's a city.
Yeah.
I mean, do you ever have any... Well, you remember at the studios, all the movie star stuff, right? So if you were a movie star and you came to the hospital, and this is true from any hospital, really, not just UCLA, then there's a whole big confidentiality thing that goes in place. And you would usually book them... Well, not book them, that's not the right word. You'd check them into the hospital. Check them in as a nomiker, a fake name, Bill Smith or something like that. And we had a lot of celebrities. Of course, they didn't want their name, that they were ill or things like that.
There's something I don't even think I've told you, but I'm going to, for the first time on air...
Is this an exclusive?
This is an exclusive. Well, it's not, Anyway, I actually had all of Marilyn Monroe's medical records.
Oh, I remember,
office,
yes.
Yeah, for several years, actually, until the studio realised where they were.
Yeah.
But... Anyway, I can't
like
talk
private
about
doctor, like doctor letters and things like that.
It was everything. Very, very interesting.
Are you going to disclose any secrets?
I can't, no.
Okay.
That come out in a book.
Oh yes, the book. All right. Let's see what else do we have with issues here.
So I got a quick hospital story when I was a copper in England, real quickie. So I arrest a chap for burglary, and he's been hit over the head by the homeowner. And his head's basically split from ear to ear. So we take him to the hospital, assuming that he was in a too bad a state to do anything else. Leave him with a doctor. I'll go out to get a cup of tea and do what you do when you're a copper in an hospital. Come back, no prisoner. So I say to the doctor, "Where's the prisoner gone?" And the window's open. And he said, well, he just climbed through the window. So there's a lesson for all you coppers out there. Don't leave your prisoners.
Well, and they're not focused on security.
No.
That's not the doctor's focus, right? Yeah.
Well,
I mean, we had one issue we had in some hospitals were the traveling nurses that are on contract. They call them contract nurses, right? So they get hired.
Traveling nurses, is that what they call?
Yeah, it's one term. I mean, they come in from... Arkansas, because there's a shortage in LA, right? And they get a contract.
Oh, okay.
Sometimes they get a signing bonus, $20,000 to show up. They stay for 6 months and they leave. And I'm not picking on the nursing industry because the young lady in my house that uses tuition is going to be a nurse, right? So I'm behind you 100%. But sometimes these people that are transitory employees, we would call them in a hospital, right? Where they're coming and going part-timers. When those people came in, sometimes thefts went up, and you had to look at those issues. And, then sometimes you had conflicts in hospitals. You either had Nurse Ratchet, that kind of pissed everybody off, or you had Nurse Betty, who was kind of out there and loopy and, So all the personalities, highly educated people. There's no dummies working in hospitals. I mean, the lowest technician is smart, right? But the social aspect of the conflicts between everybody, how to keep that straight is always an issue. And this is why I think all these things are ripe for active shooter stuff.
Yeah.
Right? It's just really a super interesting topic.
I think you've got to admire anybody that works in the healthcare industry now. It's hard work. Dealing with people's illnesses and industry, it's... and
to keep it all straight, I mean, you really have to have a comprehensive health plan, healthcare security plan. I mean, I can't tell how many times people leaked things in the National Enquirer, and it just came out of some clerk sitting at a desk when computer security wasn't really big.
Yeah.
And they just pulled up some RISE record and said, oh, hey, this guy has terminal this or terminal that. So it was, it's kind of...
So is HIPAA taking care of all that, you think?
I don't think so. I mean, they try. I mean, those things were in place a long time ago, but there's penalties. But how do you enforce it, and how do you keep track?
I
of it?
wonder if our expert would know about that.
I don't know, because we're just a couple of guys that don't know
That's
anything about security, because people stop paying us, and that's why we bring in our experts. Like today's expert, what a coincidence, we happen to have one right here in studio about hospital security, Mr. Dean P. Morris. So Mr. Morris has over 20 years of leadership experience delivering consistent bottom-line results with a significant record of accomplishments in startup operations and upgrading existing operations in healthcare environments specifically. He's the president and CEO of Corporate Services Group 360. So log into his website. That's corporateservicesgroup360.com. They're a boutique company that specializes in security, emergency management with a specific emphasis in healthcare. Some of these engagements Dean's been involved in include the development of the 2009, 2010, 2011, and 2012 California Statewide Medical and Health Exercise Programs and the California Emergency Operations Plan. So he's been in the thick of it, working on this stuff. He previously served as the Director of Safety and Security for Huntington Memorial Hospital in Pasadena, and has been in leadership positions for Securitas Security Services in the healthcare division, where he led a large contract. I'm having trouble speaking today. I don't know what that is.
I've noticed.
Sorry about that.
Must have been that vodka.
Okay. Dean, welcome.
Thank you. Thanks for having me.
We, Paul and I have always thought this is a hot topic, and we're really glad you came on, because I think most people are under the illusion, so to speak, that hospitals are that much more secure, that much more well-run. Not to pick on them, they're just a big operation, and bureaucracies like anybody else, and they have their issues. But they're certainly not like Grey's Anatomy or ER, maybe except for the social aspect, because that stuff does go on in hospitals, the social part. So am I right?
Well, clearly you've got the intern, my wife watches Grey's Anatomy and those other shows, and, I have to walk away. But interns are very tired all the time. I mean, they're working around the clock. They're typically living at the hospital. Doctors are, like everybody else, they've got their own quirks, and it's an amazing place to work. It really is.
So what's different about healthcare security from other types of security? What's unique about it?
Well, I think healthcare is very similar to a lot of open campus environments. But really where healthcare is unique is who's your customer. In typical environments, you know who your customer is. Well, for us, physicians are the number one customer, right? You've got the physicians bring the patients, who are also our customers.
I wouldn't have thought about it that way.
So it's a complex environment. And
so do the physicians participate in the security decisions that much?
Yes.
Oh, I never would have thought about that.
Yeah.
In what way?
Well, in a lot of cases now, and especially it started with emergency management planning, but physician involvement in a lot of committees and a lot of efforts it's right there. You've got leadership that's your chief of staff of a hospital. And the trend has been getting the physicians more and more involved. Because
like on the boards and things like that.
On committees.
Interesting.
Right?
I never would have thought about it that way.
Absolutely.
So are they, they're involved in it. Do they understand the security portion?
That's clearly the challenge, right,
Yeah.
is taking what they see on TV as far as security is concerned and applying it and educating. So from a security leadership perspective, a lot of what we do is educate.
Yeah.
Educate the executive team, educate the physicians, and work with them.
So do you find that, like in emergency rooms, for example, where some emergency rooms, people might not know this, but they're kind of a franchise owned and operated by maybe a physician in some hospitals. Do they have more control in those kind of environments where they're kind of the boss of the emergency room, so to speak, or the owner almost of a business kind of?
Well, yeah. I mean, there are some complex relationships, and not one hospital is the same as another.
Right.
And in some cases, the hospital has contracted out some services. In some cases, it's a separate entity, and they're a majority holder or they're a minority holder. And, providing security services, it gets complex as to, well, can we contract our services out to this other entity? Even though it looks like it's the same organization, it may not be the same organization.
Oh, you mean there may be different security entities within one hospital? A contractor, an in-house?
There could be.
Mixes.
There could be.
That
yeah,
would
I
be,
think I've seen that.
that would be challenging.
Yeah.
What do you prefer? Do you prefer in-house or contract?
Oh, that's a good one. It's complex. I think you've got to look at it with eyes wide open from a risk management perspective. And to sit and look at it and say, I like contract, you've really got to look at it, and you got to determine whether or not, what's the reason for going contract,
Yeah.
right? Or what's the reason for going in-house? Is it something that's not working, and is that the true problem? Is it because you think you can reduce costs? And then you got to compare apples to apples. Are you really saving money when you look at the total costs? Are you? So it's a really complex thing.
Hold that thought. We're going to take a break. Be back in a minute on Security Guy Radio. Welcome back to Security Guy Radio with Chuck, Full Speed Dial Harold, and Paul.
Tally ho, Bristow.
You got a question for Mr. Doug?
So we was talking about the contract versus in-house. Now I've seen hospitals going away from the contract side. I mean, have you seen that?
You know, it's always bounced around depending on really money, right? And I think in a lot of cases they make the decision for the wrong reasons.
Yeah.
And I tend to be a big proponent of outsourcing a lot of things that aren't your core competencies. Security is a tough one. The more it's integrated, I think, with patient care, the more I would recommend going in-house with it, all things being equal. Right?
So how do you integrate that with patient care? I mean, explain that a little bit.
It's everything from how you integrate with patient controls, how you integrate with the care teams, if you've got a psych unit and you're integrated with that. It also integration in other parts of the hospital with regards to IT and how well it's all integrated. If it's a separate unit and it's out there and it's got a very limited role, then it's not so complex and it's easier to contract out.
So it really sort of falls in the training area, right? I mean,
yeah, and again, training, you could contract out training, and it goes back to quality in all things. But like I said, if you're looking at it from a risk management perspective, and you're comparing apples to apples, it's easier to say, okay, we're going to accept the same level of salary, we're going to accept the same level of quality, we're going to accept all these things as being equal, then that's fine. But if you're going to go from an in-house or let's say a contract and want to go in-house, you got to make sure you're capturing all those costs, because there's a lot of indirect costs too. So what I don't like seeing is hospitals making the decision to go from in-house to contract because they think they're saving money, and really all they're doing is cutting their salaries. And if that's what you're doing, that's fine, but recognize you're not doing it based on risk.
Well, I think the integration part is key here because it's very difficult to take a contract guard company and integrate them into the hospital system for all kinds of legal reasons.
Right.
You got co-employment and all that kind of stuff, right? So a friend of mine used to work with as a cop many years ago. She works at a hospital in Orange County, and she was charged with building a emergency operations center. Mm-hmm. Apparently they don't have one. And if I've said this hospital's name, you'd say, what? But they don't have one. And they didn't have policies on, how to integrate commands between the command and control, right? So if you're going to evacuate the hospital, who gives that call? Is it security? Is it the admin?
Right.
What if admin is down and out and can't make the call? There are no policies at this particular place.
Right.
And her challenge was to kind of put this together. And I found it fascinating. Do you find that in your experience that a lot of hospitals have, I guess, old infrastructure? Is that a good way to say it?
Oh, absolutely.
Why is that?
I don't know. It's one of the uniquenesses. I always like, and we talked about the cultures and stuff earlier, but I always like hospitals as part government and part academic.
That's interesting.
Right? It's kind of a combination of government and academic, and the academic part meaning faculty versus, your doctors and all the everybody can say no, but nobody can say yes. So that's from the cultural perspective. Yeah. And really, when you look at the hardships hospitals are faced with reimbursements and costs and expense control and all that stuff, they're just struggling to stay alive. So security becomes really an afterthought, and it's trying to make sure that the security professional involved is selling security based on risk levels. And look, if there's no risk level there, drop your security down.
Okay, but aren't there standards under HIPAA that require certain minimals for that?
Well, HIPAA is basically information security for the most part. There are some physical security aspects to it. But the Joint Commission is another, and we were going to talk about that a little bit, but accreditation standards, and that's all tied to funding, Medicare funding, and those types of things, to where the hospital, if they lose their accreditation, it's a pretty big deal. So, when you start looking at reasonable or security, really the accreditation standards give it some teeth.
When JCO comes in, do they actually look? How deeply do they look at the security function? I mean, how deeply do they get into the training and certification of the guards? Do they actually look at that sort of stuff?
They do, and they use a really interesting method as far as they call it tracer methodology, where they'll follow a patient from kind of one end to another.
Oh, interesting.
And in a lot of cases, they'll see a patient going through the ER and find out, okay, he becomes a little violent or something, and do the people have the training to deal with that? So in that respect, it hits security pretty evenly. Security isn't as strong of a focus as emergency management is in hospitals, which, again, it's another nice to have. In a lot of cases, hospitals think, I'm struggling with making my day-to-day business operations. I don't have the money or energy to focus on emergency management. Well, the accreditation standards say you don't have a choice. You have to.
Right.
And it's good that they do that, because in the past, when they didn't, a lot of hospitals would just ignore it.
Well, emergency planning is for something that happens after the fact. There's a disaster, and I got to respond to it. But if you have proactive security,
Right.
you're preventing some emergency, so to speak.
And how do you measure that?
Right.
So JCO doesn't actually
Tell people what JCO means, by the way.
Joint Commission.
It's
blah, blah,
they
blah,
now
whatever
call
that
it. Yeah,
is.
they've tried to walk away from that moniker, but it's the Joint Commission, or the JC, or the TJC.
Yeah.
But yeah, they do have a security standards. Security and safety standards have been combined, and there are standards for it. And like I said, they're not. They're best practices. They're not anything out of the box. And what I like about it is they say, hey, you have to do risk assessments. And based on your risk assessments, you have to have mitigation plans. And based on those mitigation plans, you have to have training. So it's everything everybody does anyways. It's just they've kind of mandated it.
Okay, so hospitals are fraught with all kinds of things like I talked about, right? They're little cities, and they have their own issues, unique to healthcare and not so unique, right? What do you think about my my prediction that this is the new active shooter location, based on people's rage with the Unaffordable Health Care Act?
Yeah, well, we've had some active shooters locally here. We've had a lot of. There was a shooter in Reno, December. A guy tried to kill his wife as a mercy killing. There's just been some studies released that went over about I think it's a 7 or 10 year period, showing profiles, and it's split kind of evenly between them happening in the ER and them happening in the parking lot.
Is there an increase? Have you seen?
They're still pretty rare.
Okay.
And I think you're right. I think hospitals, they do have an increased risk as people get frustrated. But, you hear all the time, the 13-hour wait in the ER.
Oh, yeah.
And hospitals are re-engineering how they operate. They're re-engineering that ER flow, which I think is critical to some of those issues. And if they do that effectively, if they push those ER visits that aren't ER visits, and they push them to more of a critical care, or an urgent care, and get that away from the critical care stuff, it'll make some of that go down much easier.
So I can see if you have a guard service guarding a business in Hollywood, armed guards, part of the environment, makes sense. Hospital, maybe not so much. Guns, we don't like guns, that's not good. But if you didn't have an armed response, and we've talked about this in our previous shows about active shooters in environments and workplace shootings, 40% of all workplace violence issues, and active shooters specifically sometimes, come from domestic violence issues.
Right.
Like you just talked about in Reno, right?
Right.
And it takes between 2 to 8 minutes for a shooting, and every 2 minutes 2 to 4 people get shot, but the police don't get there for 10 minutes on average. What do hospitals think about armed guards? What do you find in most hospitals? I go to different hospitals, and I see unarmed. That's what I see.
I don't think I've ever seen an armed guard.
I think there was. I think.
Well, I think a lot in New York do, don't they? New York.
Well, I mean, if you're a psych hospital, sometimes I don't know, but
actually, it's the other way around. Psych hospitals, most of the law enforcement have to check their weapons in.
Yeah, I had to do that.
Issues with that.
Yeah,
but I do think that there's a trend in hospitals to avoid being armed. I think as a culture.
That's what I'm thinking, right?
Yeah, and again, I think it's got to go back to risk management. And I know when I looked at our hospitals, we looked at the past incidents and said, is a gun going to help or hurt this situation? And we went through 10, 15 years of incidents. We looked at tasers. Is a gun going to help or hurt this incident? And I think everybody has to look at that separately and based on their histories.
Did you bring any stats today? We love statistics on the show.
I did bring the active shooter study they did. This is from 2000 to 2011. It was from people from Johns Hopkins who had a shooting, and they
that was
put
a big
team,
one.
right?
Yeah.
And I'll just give you the highlights. They looked at about 154 hospital-related shootings during that time period. 59%.
Wait a minute, 154?
What was the time period?
150, 2000 to 2011, so 11 years.
But of hospital shootings specifically?
Hospital
well, of
shootings.
course, ERs get a lot of stuff with gangs and all kinds of things.
Yeah.
Okay, makes sense.
59% inside the hospital and 41% on hospital grounds.
Huh, interesting.
They occurred in 40 states, 235 injured or dead victims. Perpetrators were overwhelmingly men by 91%, but represented a whole range of age groups, so there's no real profile.
Okay.
The ED environment was the most common with 29%, followed closely by the parking lot at 23%, and then patient rooms at 19%.
I wonder if the parking
Oh,
lot
that's
was
interesting.
domestic violence, intimate spouse stuff.
Yeah.
Because that tends to happen in parking lots a
Well,
lot.
and we had one, I think Long Beach had one, I think City of Hope. This is motive. 27% was grudge. So that's really...
Were they employees or could be anybody in the
This
grudge?
doesn't break it down
Okay.
at that level there. And then 21% were suicides.
Well, we
No,
talked
that's-
about that earlier, right? That was common, yeah.
Right. And then 14% were euthanizing an ill relative, which the one in Reno, for example.
Oh, that's probably the patient rooms,
right.
I would imagine.
Exactly.
Yeah.
Okay. But they're
And-
using guns in that scenario?
Yeah.
Interesting. All right.
And then 11% were prisoner escapes. So it goes back to your comment before about some hospitals are
Yeah.
treatment centers for prisoners, and there's
Well,
a whole
right.
other risk level there.
Yeah.
Yeah.
Very
So,
interesting.
so probably the grudge stuff is people not getting the medical care that they thought they should.
Right.
Not necessarily they didn't get it, but
Right.
what
Or
they
even
were
workplace
thinking.
violence.
Yeah, yeah, very interesting.
Now those numbers seem significant to me. Low?
I
No,
think
they-
they're low.
I wouldn't
in
think in
10
a ho-
years, 154. That's low.
Well,
What's going to be
in
interesting
10 years?
to see if,
Okay.
see if it goes up.
If we had 154 shootings in schools in 10 years, no.
Well,
I wonder how many
here's
schools
the
are-
OSHA stat that
This
they,
is why this is interesting because schools are targets for all kinds of reasons. Bullying, more specific. Hospitals, because of all the different issues, I think, are more prone
But you
to
haven't
this.
got the public in the schools so much. I mean, you've got a lot of public in these hospitals.
That's why I think it's a more volatile situation.
Oh, I agree.
Brian, are we due for a break? All right, roll the music. Here it comes. Excellent. Back in a minute on Security Guy Radio. Welcome back to Security Guy Radio with Chuck Harold and Paul Bristow. We're talking with Dean P. Morris, CPP, CHPA. Well, I know what
Oh, it's
CPP
the
is. What's
alphabet
what's CHPA?
Certified Healthcare Protection Administrator.
Oh, excellent.
Oh,
Very good.
you couldn't remember
That's
that.
impressive,
didn't you?
yeah, I
You
know.
almost forgot that, didn't you?
Yeah, I know. Yeah, I leave it off a lot.
I'm just a junior. That's all I am. I have anything else except JR after my name. But all right, so we're talking about some stats here on active shooters in the workplace, and those stats we just talked about were for shooting incidents, not other violent incidents, which of course will be a whole other set of stats. Mr. Bristow disagrees with me. He thinks that number's low. I think it's high.
I think it's high compared with other places, but I still think it's low compared with the energy and the volatility,
can't
whatever,
get one of our American words, can you? All right.
that goes on in the healthcare
Yeah,
industry.
no,
I
I-
think it's just a place where you'd expect.
Well, and I'll support
lot
that
more,
with one
you
of the
know?
facts here. I think this is from OSHA, or Department of Labor. The rate of assaults on healthcare workers is 8 out of 10,000, compared out of 2 out of 10,000
Yeah.
for private sector industries.
Wow, that's interesting.
So healthcare is one of the top.
Now, is that you
and
think,
that's assaults. That's not shootings.
I'm assuming that's from the clientele and not from other members of the healthcare industry,
Well, it could be. It could
know.
be employee on employee.
because there's a lot of bullying and stuff goes on, isn't there?
Right. Between nurses and doctors and all that
Doctors
kind of stuff. Yeah.
Did you see a lot of that?
Yeah. Oh,
Yeah.
well, I mean, tensions get high, and
Yeah.
yeah. It's very plausible that it's workplace violence mixed up with
Yeah.
the patient assaults and that type of thing. Yes.
So you just finished up working on a study about active shooting in healthcare.
Well, it wasn't so much a study. I'm involved in a couple of things. One, the hospital incident command system. I'm one of the advisory board members that authored that, and we're doing a 2014 release. And what's coming out in this 2014 release is an active shooter scenario and template and planning guide. And based on that, I was asked to join the National Infrastructure Protection Plan's healthcare sector for active shooter. So what they're going to do, and it's out of the White House, and they're going to publish active shooter planning and response in a healthcare setting. They just finished, not this group, but another critical infrastructure group, finished one for schools. So they wanted to make sure they addressed the uniqueness of the healthcare setting, which, when you think of an active shooter, how complex that is, run, hide, or fight. Well, what do you do when you've got critical patients? What do you do when you have patients that can't take care of themselves? Do you run, hide, fight? What do you tell your staff to do?
That's a tough one.
Yeah,
That is a tough one.
It is a very tough one, and
what's
there's no one answer for it.
What's going on now with it? I mean, this is going to be released in 2014 in this year.
Yes.
So what do they do now? I mean, what's the plan in now?
Well, again, that's one of the reasons why they're trying to expedite getting this out, is because there's kind of a lack of guidance for healthcare for it, because the only thing out there now is the run, hide, fight.
Yeah.
Right.
And again, what this document's trying to do is make sure that it stems the discussion in healthcare environments. So think about it in advance, right?
Wait, did I just hear another Security Guy radio exclusive that this report is
Yeah.
not out yet?
That's true.
Excellent. We're
Yeah.
hearing about it. Is this the first place you've talked about it?
It is.
Unbelievable.
So
Another scoop, ladies
You
and
have to
gentlemen.
ask the question: I mean, active shooter's been around forever,
Right.
right? Why has it taken so long for the healthcare industry or the government to get around to actually producing some, responsible plans?
Again, this would just be my opinion, but it's not an easy answer. It's not an easy solution, and everybody likes easy, and they're tough decisions. When you start thinking about one of the terms is austere care, but taking care of patients in a disaster like Katrina, nobody wants to make the tough calls in advance saying, well, you need to save yourself and give up your patient. Nobody wants to publicize that. Nobody wants to talk through that. And this leads to some of those discussions. So when do you save yourself? When do you give up your duty to your patients, your legal obligation to your patients? How do you do that? I mean, it's complex.
I think that's the trick in healthcare. There's a positive affirmative duty to protect a patient, whereas at the grocery store there's not.
Yeah.
Right. So they're going to have to get a handle on that.
Right.
I mean, in most environments for active shooting, you train individuals to act independently, and in acting independently for their own safety, they tend to act as a group,
Right.
more so than somebody directing the group to act,
Right.
because then it becomes chaos, right?
Right.
But if you're going to barricade in place or lock down a hospital patient's room so a shooter can't get in there, you've also locked out healthcare people that can help them. I mean, it's a tricky one.
Well, and again, when you get down to how hospitals have been designed, patient rooms don't lock unless it's a
right.
locked
No, they don't.
psych ward, right?
Yeah.
So to lock down a hospital, especially with the traditional way that we built hospitals in the last 50 to 100 years, they haven't been built to lock down.
No. Well, my belief, and this won't be politically correct or popular, but
Your beliefs never are.
they never are, which is why we're on
Sorry.
radio and not working for a corporation. But let's cut to the chase, okay? So all hospitals are a box. All boxes have holes in it, and the holes are access points. And some hospitals have a lot of holes in them, and some not so much. But if you controlled access at the entry points, and you had a way to solve a shooter right there at the entry point, and when I say solve, what does that mean? Oh, you have a gun, bang, you're dead.
But let me tell you why that is, because that's been my professional challenge since I've been in healthcare, is hospital designers, engineers or architects have designed hospitals over the last 50 years to have as many access points as humanly possible.
Well, it's good from an emergency point of view.
Well, not even an emergency point of view. You got to remember, you've got patients that go from one procedure to another procedure, another procedure. So there's all this. They build doors. They build, and from a security perspective, you're trying to close all those doors and funnel them through one point.
See, but I don't agree that it's that difficult and that much of a challenge, because you can solve anything with money and will in security. That doesn't. And by the way, that's still not 100%. No matter how much money you throw at something to barricade it, right? But if you don't have the will behind it, and I just think that it's politically not popular to have 35 entrances at the Center for Health Sciences and have 35 armed guards standing there.
Right.
It just ain't going to happen.
Yeah.
I mean, until what?
Until something
Something
happens.
really bad
Well,
happens.
I'll give you an example. There was a hospital that'll be unnamed that had a incident where somebody came over the counter in the ER and went in and assaulted a bunch of people. So they put in a bulletproof glass and they put in glass. Well, then when they went to redesign the ER, they wanted to remove the glass because they wanted to have better patient access and more of a friendly atmosphere. So instead of talking through and saying, okay, how do we do both?
Right.
They just drop it down and then you get the same problem again.
What in that report, what can you tell us about that kind of scenario I just proposed? Are they talking about things like that? Are those solutions that are proposed, although maybe they're not really acceptable?
Or is it more of a reactive?
No, I think
plan?
What this document's trying to do is it's trying to prompt the discussions internally. It's trying to, because there were some people on this committee, the Hospital Corporation of America, who owns a lot of hospitals. The FBI was on the committee. The White House was on the committee. Hospital Association, California Hospital Association was on the committee.
I'm glad you were on the committee.
And you were the only security person, right?
You know, not the only person, but no, there were a couple of us.
Not the FBI, not
well,
the White House.
It's
Okay.
amazing how political some of these things are.
Oh.
But again, it's trying to make sure that they're prompting the discussions with attorneys, even with your corporation, with your hospitals, and say, okay, let's talk through this. How are we going to do? And then train to it.
Okay, so here's what we know about active shooters from what I've studied in schools, McDonald's, whatever. I forgot the number, but it's something like 85% of the time, if the cops say, "Hey, you, what are you doing?" Boom, the guy shoots himself in the head or gets shot by the cops.
Right.
Okay. Or literally, if a victim challenges the shooter physically, throwing something at him, whatever, they tend to stop, kill themselves, or give up.
Right.
So my suggestion is if you had armed people at these access points, we know that in some cases, like the Colorado theater shooting, right?
Mm-hmm.
That guy was going to go to the theater by his house, but he didn't because there's a guard there. And he chose the one that didn't have a guard. That was not an armed guard, by the way. So the personality of the people that are shooters tend to be non-confrontational, although
Right.
you would argue they have a gun, they're confrontational. But that's
soft targets.
yeah, right.
Yeah.
And they're not going to challenge them. That's why
Yeah.
kids get shot because they get under a desk, right? So I mean, I'm glad you're there because these other people you're mentioning, they don't know anything about security. I'm sorry.
Well, and again, you ask people.
They know about politics and they know
Right.
about laws and things like that. But
yeah, what keeps you up at night? And,
Right.
It's the inability to screen people before they get there.
But I'm glad somebody's
Yeah.
looking at it because I was worried that this was not really being.
Well, when they're looking at this for this report, are they looking at all hospitals as one big entity, or are they looking at, as they work now, unfortunately, all separately?
Well, that they are separate,
Yeah.
and that's one of the challenges is that you're not dictating anything, nothing's controlled. So hopefully, one of the things the Joint Commission has done real well is it's created a de facto industry standard, and
Yeah.
they look at real life
Yeah.
incidences and they come back and they've tweaked emergency management as a result of it, and hopefully, they're going to do the same thing with security. And I
Well,
don't look at I don't look at the Joint Commission as a negative. I look at
Yeah.
it as a
All
way
right.
to really take best practices and
Yeah.
hold people accountable.
That's sort of where I was going. I mean, it's if they involve the Joint Commission and made it almost a federal standard, this is what you have to do,
Yeah.
and then enforce it.
Well.
Who's the
That might
decision
work.
maker in these scenarios most of the time? So let's say this passes some best practices. It goes up the chain to a hospital. There's the chief executive officer of the hospital that
Mhm.
runs it. Who's the person that's going to pull the trigger is not the right way to say that, is it? Phrasing. Who's going to make the decision to implement, non-implement, to go which direction? It's not delegated down to the security guy, that's for sure. but
No,
do
no,
they
it's not.
participate?
Right. And again, I think I've mentioned before how difficult it is to lead initiatives through securities with everybody saying no and nobody saying yes.
Right.
And again, you're going to bring physician groups in, you're going to get their involvement, and you're going to bring nurses in, you're going to get their involvement. And let me tell you, nurses can be the biggest proponent of security
Oh, absolutely.
there is.
Oh,
And
yeah.
in a
Oh,
lot
yeah.
of cases, when I have to go to HR and say, hey, I want this, it helps with nurse recruiting and because nurses want to work
Yeah.
where they feel safe.
Have you found in any of your travels that nurses, doctors, health coworkers are packing on the job? Nobody knows about it?
Well, not in California.
No?
Everybody, no.
Oh, we had a lot of people at the studio that aren't supposed to be carrying guns that we
Yeah.
found in their trunks all the time. It
Well,
happens.
After the riots, when we
Oh, boy.
when we decided to search everybody's trunk,
Yeah.
I think we found, in the first day, we found like 30 people that were carrying firearms.
Right.
I mean,
Yeah.
it was
Wow.
crazy stuff.
Yeah.
But has anybody tried, from the prevention point of view, like searching people before they come into hospitals?
Well,
How does that come about?
Hold that thought. I hear the Brian the
drumming.
Engineer music playing. Back in a minute on Security Guy Radio. Back with our ambulatory segment of Security Guy Radio with Chuck Ospedal Harold and Paul.
Tally-ho.
No, we got to come up with a
No,
healthcare.
I still like it.
Paul.
Oh, yeah.
I'll think of it next week. We
Well, talking about healthcare real quick, did everybody see the Olympics from London? So what did you think about the National Health Service beds being pushed around? Was everybody really impressed with that?
That was kind of funny, actually. That was very funny.
Yeah.
Dean, we got so much to cover. We only have like 10, 12 minutes left, but you're going to come back?
Yeah, if you want me
All
to,
right.
sure.
Absolutely want you to.
All right.
Let's jump into some things that...
Well, can we just finish up with one
No,
issue?
not your terrible idea.
No.
Okay, go ahead.
No, not that,
All
actually.
right.
Because this all seems like a reactive plan to me. I mean, what's being looked at to stop it? Like searching before people go in hospitals? I mean, is that coming into this plan?
Well, I think you're talking about culture change for hospitals, and I think a lot of the hospitals that want to have access control kind of want to, but they don't want to, so it's kind of a half-hearted attempt. Some are doing it really well, but I think we're in the process of that shift. We're in the process of saying, well, it's not really going to happen here, and I think you're seeing more and more visitor control, and then hopefully what you're seeing, I hope we're seeing, is architects getting on board.
That's an excellent
funding.
idea. Right.
And really, for me as a security director, if I can get involved with the architects early on in planning and at least be at the table, because half the time it's all done, and then they say, oh, come on in and plot down your low voltage stuff, and by then it's too late.
We had
seems
that.
to be
Well, remember at Fox, they built the Fox Network Center, and I forgot the name of the company that they contracted with it. But
Was it
that
Hathaway?
company, was it Morrow?
I can't remember.
Might have been Hathaway. Anyway, they're big construction business with hospitals,
Mm-hmm.
and the Fox Network Center wound up looking just like a hospital.
Oh, wow.
Yeah.
All these doors, and we had the same challenge you had.
Yeah.
Wait a minute, let's come in here on the blueprints and change this, put a camera and stuff
Yeah.
like that. So it's very interesting. Now, you were mentioning something in the break you wanted to get into and talk about.
Well, I was just talking about some of the complexities of training for security officers and what a challenge it is for them to use some judgment. And one of the reasons why healthcare security is so much harder, I think, than most of the other security operations. You've got a security officer who knows what they're making at a particular hospital, and here they've got an issue, maybe not even in the ER. Maybe it's somebody walking to the ER and they're being assaultive, and, well, is that a suspect? Do you put handcuffs on them? Do you call the police? Or are they coming to be seen as a patient? Do you have to treat them as a
They're
patient?
technically a patient, right?
They're technically a patient.
Now, what designates them as a patient? Is there some kind of code or something? Or
There isn't. It's just that if somebody's presenting to the hospital and there's a reasonable intent that they're trying to be seen there, they're a patient, even though they haven't been seen.
I see. Okay.
And I'll give you an example. One of the hospitals that I've worked for, they had a homicide recently, last year or a year, I guess it's 2 years now. And again, it was a homeless guy showing up, and somebody felt threatened by the homeless guy and ended up getting in a scuffle and ended up stabbing the homeless guy
Well, at the hospital.
at the hospital before the homeless guy made it into the ER.
Oh, so two people that were technically patients, so to speak.
No, one was an employee
Oh.
who was walking by and felt threatened by this homeless guy, not knowing what he was doing or saying. Maybe he said, I wasn't there, so I don't know.
So would he just come out of surgery, was carrying a knife or something?
Yeah.
Or what?
What's that all about?
Box cutter.
Oh, good.
Yeah. Those darn box cutters.
Yeah.
Yeah.
Let's talk about the infrastructure we've touched on earlier. So much of the infrastructure in hospitals. Well, America is very young, yet it's aging, right? Things are 40, 50 years old, which is not as old as jolly old England. But, the infrastructure is failing. And when you work for the company that shall not be named, they had a product that was an anti-child theft product, right? I know that we at that company had 600 of those in 600 hospitals. And that's something I think people would be interested in. Have you come across that? The different types of system. There's Hugs. That's a popular one. My Child's another popular
We're
one.
talking about infant protection.
Infant protection.
Yeah.
So if somebody tries to take baby out of the hospital locks down.
Right.
it's interesting you're talking about integration where this part of the hospital doesn't really have security. The ER puts in their own cameras, but the baby part, they seem to have that together in most hospitals.
They do.
Is that what you found?
Oh, absolutely. And it's been a joint commission standard for I don't even know how long.
And that's because people don't like children being harmed.
Right.
And that's why the schools get all the press, to your point, Paul, about school shootings when there's not as many of those as there are workplace/hospitals and things. Interesting.
It's funny when I do risk assessments or when I see risk assessments that have been done, you want to pair your risk assessment up with your mitigation plan. Well, the mitigation plan for infant protection is up here.
Right, the
but
highest.
Yet the risk is pretty low
Yeah,
comparatively to some risks that are out there.
Meaning if a hospital doesn't have protection, an infant protection system, they still don't have as high a probabilities of a child kidnapping?
Well, take an active shooter risk compared to an infant abduction risk. Now, again, I've always thought, well, an infant abduction is going to kill you reputation-wise. Well, we've seen some here, even in Southern California. It didn't happen. I mean, I would have turned in my resignation and walked away.
Right.
But it doesn't have the impact, or it didn't have the impact in these situations that an active shooter is going to have.
That's interesting. I
Well,
that.
and the victims are a lot less, aren't they? I mean, it's terrible if you
Right.
get
Right.
an infant abduction, but you're only looking at
So
one
again,
child.
or a family.
not
that's affected.
I'm not going to complain that everybody's prepared for it. I'm just saying
Yeah.
you got to look at your risks and say, hey, what am I doing to mitigate my risks?
What's going on with asset tracking in healthcare environments? Got a lot of expensive equipment. You got a lot of people, don't bring your gold watch that grandma gave you, but they bring it anyway.
Yeah.
You still see a lot of those thefts and things?
Yeah, cell phone thefts all the time. I mean, iPhones running away like crazy.
Well, that's what we was talking about a couple of weeks ago, wasn't it?
100 per
Cell phone
minute in the United States.
Yeah.
Smartphones are stolen.
Yeah, you just got to say, hey, leave them at home, or it's your responsibility. I'm not going to buy you a new iPhone.
It was interesting when I was working for another company before.
The company that should not be named?
A big thing was asset tracking and asset protection in the hospitals,
Yeah.
and it was interesting what was actually being stolen, like breast pumps and some
things have some value
weird,
in the outside market.
Yeah, or it's being moved around the hospital. Actually, wheelchairs was a big deal. So is that still huge? Wheelchairs?
Huge. Yeah, hospitals go through wheelchairs like crazy, and they do all kinds of things to try to prevent thefts or
Wheelchairs are the
walking
shopping
away.
carts of a grocery store.
They really are.
Yeah.
If you're you got to get around on the bus, or you can't carry your stuff home, then I could say they're very expensive.
They are. And again, the bigger issue, it really isn't a security issue so much as it's a maintenance issue, is preventive maintenance. They're trying to do preventive maintenance on equipment that there's cracks and crevices all over the hospital. You got to find that stuff.
We talked earlier, touched on it, about threat management perspective involving bullying of nurses by doctors. There's bullying by patients, but you kind of almost have to accept that. That's just your job. But you don't have to accept bullying by doctors of nurses. How prevalent is that?
I don't know. I think a lot of it goes to leadership, in what's acceptable behavior and what's not. And like I said, hospitals are complex places where the physicians have a lot of say, and rightfully so, they're business partners. Doesn't give them a right to treat people certain ways, but again, there's politics involved, and hopefully you've got a strong chief of medical staff that can take some appropriate action with physicians. And in a lot of cases, that's what we had to do, is we had to involve some higher ups, and as long as you got support at that level, it's helpful.
Who has to deal with the ER responses? I would assume ERs are the most violent place in a hospital.
Yeah,
Just a guess.
Well, and I'll tell you what, I've worked in areas where they've also have locked psych wards. In a lot of cases, what's happening is they get so full with beds, they've got potential psych patients stacking up in the hallways in the ER with no place to bring them.
That's got to be interesting.
That's where it gets crazy.
Yeah.
Oh. Well, I remember I used to get called up to the psych ward to 5150 patients, commit patients on 72-hour hold, because a psychologist cannot do it. A medical doctor in the ER cannot do it. And so, they would, instead of putting them in the hallway, they would send them up to the psych ward earlier because, we'll just have somebody come in here and do the old 5150. And I would disagree sometimes and say, they know what day it is and what time it is, so we're not going to commit them. But do they use psych wards as hospital beds for non-psych patients sometimes if it gets overflowed?
Typically what they do is they try to medically clear them in the ER first. So even though you may have a known, we call them frequent flyers, known psych patient in the ER, they want to make sure they clear them medically before they move them on to psych treatment. And that's typically what's happening, is they're waiting They get cleared medically, and then they've got to go.
Is there a difference between, from a security perspective, between the sort of Medicaid hospitals and the privately ran, or is it basically still the same?
They're all complex, and again, we've talked about how the integration of security with things. Well, it's the same thing. It just depends on all the different services being provided by that facility and how complex that is. And
I mean, is it more difficult to get financing for the security stuff from a state-run hospital, or is it just about the same?
So we only got about 30 seconds left. Associations specific to the healthcare security industry. What do you got?
Well, obviously has a healthcare chapter or healthcare committee. The International Association of Safety and Security, IHSS. They're very
IHSS,
strong.
yeah, that's a big one, right?
They're very strong. And then again, some of the hospital associations have committees where they pull together security directors from their areas, and they're pretty strong councils.
Excellent. My guest has been Dean P. Morris, CPP, CHPA of Corporate Services Group 360.com. Is that the best way to get a hold of you?
Sure.
You want to give out your email?
Sure.
What is it?
It's dean.morris@csg-360.com.
Excellent. We come back?
Yeah, absolutely.
All right, we'll do another
It's been
segment.
fun.
Yeah,
Thank
Yeah,
you.
there's so much to learn in this area. So, all right, well, that's been another ambulatory version of Security Guy Radio. We thank you again, Mr. Chuck Harold.
Paul Tally Ho, Bristol.
Signing off until next
Cheers.
Monday. Join us next Monday on Security Guy Radio. Welcome back to a special bonus edition of Security Guy Radio with Dean Morris. We're continuing our conversation for a few minutes because, Mr. Bristow, you had a fascinating, albeit highly flawed idea
I think so.
about how to solve
this is the
the.
way to go.
It's not the worst idea, but go ahead and throw it out there to Dean. See what he thinks about it.
I've always thought that, considering our the potential for hospital violence and the difference between the different security companies and in-house and all the rest of the stuff that's going on, I mean, surely there's a space there for a federally run police department that just services the healthcare industry. I'm not talking about security. I'm talking about a police department similar to the school police for LA.
The TSA for healthcare?
But not TSA. TSA security. They're not police officers.
Well,
right?
you have the what's the model? The VA has police
the
department.
VA.
VA
Yeah.
police.
Yeah.
Yeah.
So what do you think?
Well, first of all,
Because I want to lead this police department. If we can get it
you
going.
just created yourself a job, huh?
Well, here's what I think. I mean, here's one challenge you would have. In theory, good idea, not bad, right? Because you're consolidating training, leadership, all that kind of things. But do I want a federal police officer in my private hospital? I'm not so sure I do.
Why not?
Because I don't want them in my store or my restaurant or anything else. It's not a police state. We don't want the police standing around places.
So do you then assume any liability for anything that goes on, or?
Yeah, I think so.
Yeah.
The police picked it up and say that they're liable and they're going to take care of it.
Yeah, don't worry about
Yeah.
it.
It's not a bad idea, but I think it's
from a federal. I mean, there's enough federal money there. There certainly will be.
Does that go back to your socialistic?
It does to my
Socialistic
my
roots
universal health care.
good old Great Britain.
Yeah, exactly. Running around with hospital beds.
Dean, what say you?
Well, it's a capitalistic society. There's all kinds of hospitals. There's all kind of health care. There's long-term care. There's skilled nursing. There's hospitals. There's acute care. There's specialty hospitals.
Tens and hundreds of thousands of facilities.
Yeah,
literally.
and they're all different. And you've got rural hospitals. You've got inner-city hospitals. You've got hospitals with different risks. And trying to figure out staffing for hospitals, which we really didn't get into during our last episode, you're going to then take that burden on and say, okay, we're going to tell you what's an appropriate level of staff, and then we're going to bill you for it.
Well, let me go back to JACO. Now that's a federally run. Is that federally run? Or
No,
is that
it's a
just
membership.
California? Oh, okay.
And again, it's a best practices. It's a membership. You pay membership to belong to the Joint Commission.
Okay.
See, I always go back to what we talked about in our earlier shows. All security is personal, and all security is ultimately local, right? The best way to protect LAX is to have people that are vested in LAX. I would say put off-duty LAPD, sheriffs, Culver City, whatever cops running those TSA checkpoints, and I guarantee there's not going to get past them. They have pride of ownership, right?
Right.
Hey, this is my city. I'm a cop. You're not sneaking a bomb on my plane. Whereas the guard, it's lower pay, no pride of ownership. I'm not saying they do a good job. I have a lot of good TSA people. In fact, one of the best models I've seen is Seattle, where they have older people running it who are kind of old school, and they take it personally and things like that. So, to your point, I think if you make it national, I think you lose accountability. What you gain in procedures and consistency, you lose in accountability. That's my theory.
True.
I don't know.
Possibly.
Well, and again, I think it's much like emergency management. You talked about all disasters are local, right? Well, same thing with security. You've got to be able to determine what level of risk your organization wants to take. And if you've got the government coming in there and saying, okay, here's the level of risk we're going to protect you from.
Right.
So.
Well,
so I'm outvoted, am I?
not outvoted, but let's take a stronger position. By the way, do they do that in England? Who runs security in England for hospitals?
Well, actually the state. Yeah, because all the hospitals are
They're state hospitals.
They're state hospitals.
Okay, that's a good point. Now,
Yeah,
so based on that
they're
model, how does it
national
work?
hospitals. I think it works pretty well.
Are they police officers?
No, they're security. But then security is a little bit different in England than it is in
It's
the
more
States.
serious.
It's more serious. They're paid a little bit more.
Mm-hmm.
And again, because it's a state-run function, then the security people work for the state, basically. So it's a little bit different than what's going on over here. But then it's a lot smaller.
It is. Well, and all my conspiracy theory friends, Steve, you know who you are, I can see a scenario where if the federal police department is in all the private sector hospitals, and all of a sudden the government says, this Affordable Care Act ain't working out. We got to go to single payer. We're taking over all the hospitals.
Well, I think that's the way it's going to go anyway. Which is what should have happened in the first place, personally.
Well, then I don't want people with guns in there telling me that I can't run my hospital anymore, right? Not too far crazy. I mean, crazier things have happened in a shorter period of time. So it's not a bad idea. And if there's a model in England, it's something to think about. But I think you lose the effectiveness locally because locally, that hospital knows what's best for that area in that time. That's what I'm thinking. Dean, what do you think? Who wins the argument?
I think you've got this one. Sorry, Paul.
Sorry.
Yeah.
Sorry, mate.
Can I say?
Sorry, mate.
Thanks for staying with us for a little bonus segment here on Security Guy Radio. We'll join Mr. Bristol and myself next Monday, for another full episode. Good night.
Cheers.